Namrata, and good afternoon, everybody who is participating in this very exciting workshop. Um, we are going to be learning quite a lot through this workshop. The title of my talk will be to discuss with you some of the aspects that we confront whenever we are treating cases of microbial keratitis in general and bacterial keratitis in particular. The objectives of my talk will be to give an answer to the question, what is the role of microbiology in the management of corneal ulcer? This has been touched by previous speaker, but I'll be putting a scenario to it so that you can use this tool judiciously. We will also discuss what is the role of fluoroquinolone versus fortified drops. Is there a role of corticosteroid in the management of corneal infections, especially bacterial keratitis? Let us look at this patient who presented to us with the history of pain, redness, watering, and diminution of vision of 2 days duration. She was a soft contact lens wearer and used to sleep with the lenses on occasionally. I am sure with the clinical picture and the history, it should not be very difficult to answer the question of what is she suffering from and what is the etiology of this case. However, the question that haunts most of the clinicians who deal with this case is, even when I understand what is the most likely etiology, should I be doing corneal scraping for this patient or not? And I think if you pull out literature, both in peer-reviewed publications as well as standard textbook, you will find that the classical recommendation for any case of microbial keratitis is that in all these cases, a detailed microbiology must be performed, and the treatment is to be based on both microscopic examination as well as the growth on culture media. However, the real life situation is that close to 90% plus ophthalmologists treat these cases empirically without paying attention to the nature of organism causing these infections. And that was very clear in a large series that we analyzed, that many of these patients are indiscriminately treated with a combination of antibiotics, antifungal, antivirals, and some of these patients are treated even with corticosteroid before starting definitive treatment. Now, why this kind of a behavior is there? On one hand, a classical textbook and peer-reviewed publication highlights that all these patients must undergo microbiology, whereas we see that clinicians are not buying that recommendation and are treating cases empirically. And it is all because a classical microbiology workup comprises of microscopic examination of smear using gram stain and KOH chalcofluor white, and inoculation of multiple culture media which promote growth of bacteria, fungi, and parasite. And some of the authors even recommend use of polymerase chain reaction. If you have to know the antimicrobial susceptibility, then your lab must also be equipped to do antibiotic susceptibility either using Kirby bar disc diffusion method or E-strip. Now, all of this test, if you have to do, will require a very well-equipped laboratory, staff that is trained to handle these ocular samples, and there is cost and logistics involved. And it is because of this reason that most ophthalmologists are reluctant to either avail these facilities, even if they are available in their towns, or do not have access to the labs that are equipped so well. And that is basically the reason that these patients are treated empirically. So we are again at the crossroad of, should we be doing microbiology in every case, or are there some kind of a compromise that can be made, realizing the ground reality where most ophthalmologists do not have access to microbiology laboratory? And I think to answer this question, there was a workshop held in 2005 by World Health Organization South Asia region, where that group was tasked to develop guidelines for the management of corneal ulcer in countries where the microbiology facilities may not be available. The group considered following facts. Most of the corneal ulcers are caused by bacteria. If you for a time ignore the data that is coming from tertiary eye care center, in majority of the community centers, probably the bacteria are the most common causes of corneal ulceration. To add to this fact is another fact that most of the antibacterial agents are bactericidal, and if instituted on time, they are likely to result in resolution of infection. And there are demonstrable clinical responses seen within days of administering appropriate antibacterial therapy. Other facts that were considered were related to if we are going to miss on fungal and acanthamoeba as etiological agent. And the group thought that we have to remember that most of the antifungal agents are fungistatic. They demonstrate clinical response in weeks, not in days. And if you combine antibacterial with antifungal, then the cocktail is likely to be toxic and make the management more complicated. Further, it was also identified that if you use 10% KOH, the presence of fungal filament will guide you to initiate treatment with antifungal drug. And therefore, the microbiology workup that was recommended by the group was that a simple light microscopic examination of 10% potassium hydroxide smear can be a good tool combined with clinical assessment in starting treatment in a rational manner. What was their recommendation? The recommendation was that if you are dealing with a patient who is suffering from an ulcer which is around 2 millimeter in size and has no features of fungal or parasitic infection, then these patients can be treated even without microbiology workup. These patients can be started empirical treatment with a broad spectrum antibiotic. On the other hand, if you are having a patient who is having a large and serious ulcer, then there is no point in wasting time by empirical therapy. It is better to know your enemy and start a specific therapy as early as possible. The committee also made a recommendation that since in a country we need to know the epidemiology of corneal ulcers, they said that a teaching institution must ideally treat every patient of corneal ulcer based on the microbiology, and they must also invest into doing antimicrobial susceptibility so that they can develop guidelines that can be followed by the community ophthalmologist. The next important dilemma that we face whenever we treat corneal ulcer cases is what kind of antibiotic we should initiate. And there is always a dilemma, should I use fluoroquinolone, which are commercially available, versus should these patients be started treatment with fortified cefazolin or vancomycin or other fortified antibiotics. This dilemma is primarily because the cefazolin or vancomycin drugs are not commercially available as ophthalmic preparation. If you prepare them from injections or intravenous preparations, they have limited shelf life. There are issues with their pH and tonicity. And since they are dispensed in higher concentration, they may be toxic. On the other hand, fluoroquinolones are commercially available. Their shelf life is not an issue. They have been shown in clinical trials to be safe and non-toxic. Further, the bacterial keratitis study very clearly documented that monotherapy with fluoroquinolone was as effective as combination therapy with cefazolin and tobramycin. And there was a time, in particularly after 1990, when ciprofloxacin and ofloxacin were made available in the market, that many of the patients of corneal ulcer were treated with the monotherapy with fluoroquinolones. But unfortunately, these first generation of fluoroquinolones started developing resistance, both against keratitis isolates, but also conjunctivitis and endophthalmitis isolates. Soon, the 8-methoxyfluoroquinolones were brought in the market, And people thought that because of the dual mechanism of action, this group of antibiotics are unlikely to develop resistance, and they still maintain a broad spectrum of activity both against gram-positive and gram-negative organisms. Further, they were also effective against Cipro-resistant organisms. So there was a recommendation that we should start replacing first generation fluoroquinolones with the fourth generation fluoroquinolones in the treatment of corneal ulcer. However, the resistance monitoring of organisms against these antibiotics very clearly revealed that over a period of time, even these group of antibiotics have started showing reduced sensitivity, particularly against gram-positive organisms, and they have lost their capability of being effective against Cipro-resistant gram-negative organisms. So we are back to the square one, where we are now debating whether is it appropriate to treat patients of corneal ulcer with fluoroquinolone monotherapy. The recommendation that is currently made is that if you are treating a less severe corneal ulcer, an ulcer which is less than or equal to 2 millimeter in size, then fluoroquinolone monotherapy with a broad spectrum fluoroquinolone, that is 8-methoxyfluoroquinolone, will be a rational treatment to start with. However, if you are treating a severe corneal ulcer, then probably it will be appropriate to start treatment with fortified antibiotics, which covers both gram-positive and gram-negative, and therefore recommendation was combine fortified cefazolin with fortified aminoglycosides, or you can choose first generation fluoroquinolone because they still preserve good activity against gram-negative organisms. The next question or the next issue that will come is, should we only treat these patients with antibiotics, or can we give a combination of antibiotics and corticosteroid, or should the approach be starting treatment with antibiotic and when you have a response, add corticosteroid? If you are discussing the third issue, then it will be important that for how long should you give antibiotic before you can safely start corticosteroid. But the more important issue whenever we talk about corticosteroid is there a real benefit? And I think this question is an age-old question. There are groups which debate that in favor of corticosteroid, whereas there is another group or a school of thought which is against use of corticosteroids in the management of corneal ulcer. And this debate is as old as 1952 when the first paper was published onto the use of corticosteroid in the treatment of corneal ulcer. So almost over 70 years, we have not been able to resolve this question of what is the value of corticosteroid in the management of corneal ulcer. The believers of school in favor of corticosteroid are saying that because corneal ulcer comprises of infiltration by leukocytes, and the cytokines that are released from these leukocytes are promoter of tissue destruction. Therefore, arresting the leukocyte infiltration is going to be beneficial. So, the expectation from the use of corticosteroid is: are they reducing corneal scar? Do they use, or is the use of corticosteroid results in improved visual acuity? And does it really shorten the duration of disease? And I think all of these are of questionable value. But the most important question that always haunts a clinician in using corticosteroid is, are they safe? Are they not going to be worsening the clinical situation? Kirk Wilhelmus published this beautiful article in 2002 where he tried to do the meta-analysis of all the literature that was published until that point of time and talked about indecision about the use of corticosteroids for bacterial keratitis. He found that most of the literature very clearly documents that prior corticosteroid therapy can lead to worse outcome in patients of bacterial keratitis. And similar were the results when corticosteroid is administered simultaneously with antibiotic at the start of treatment. What he found is that nobody has really looked until 2002 on the issue of antibiotics followed by corticosteroids. And this was the rationale for the SCUT trial that was done to ascertain what is the true value of corticosteroids. However, the study, which was a very high class, the study did not find any difference in the group that was treated with corticosteroid versus those which were treated with placebo, as far as best spectacle corrected visual acuity is concerned. The group also did not find any major difference in the side effects or the complications. They performed subgroup analysis and then thought that probably the only value corticosteroid may have is in the management of severe corneal ulcer. They concluded that there is no major safety concern, but there are no major overall value that corticosteroid therapy has. Subsequent to this, there was a Cochrane review that was published that again looked into various evidences that have been in the literature so far, and they also did not find any beneficial effect of use of corticosteroid. So what is the sense that we can make from these studies? And I think it is very clear that at this point of time, we do not have very conclusive effect, benefit in the use of corticosteroid for corneal ulcer. Let me now end by showing you a case which highlight another dilemma that we face, that when many times you start an appropriate therapy and still the patients are not benefited. This 25-year male who presented with a 6-week history of following a corneal foreign body removal, we did corneal scraping, the smears were negative and culture showed a growth of Corynebacterium on one medium. We started patient on ciprofloxacin. This is a case we saw in 98, and atropine eye drop. Patient showed initial response, but then there was a worsening almost at 4 weeks. We changed drugs to cefazolin, again showed some response, and then came with the increase in symptoms. At that point of time, we thought, what is happening? We are treating based on microbiology, we are using antibiotics, and still this patient is not showing response. We paid attention to the history and the clinical course, and it was very obvious to us that there are certain features that we should pay attention to rather than empirically switching to another antibiotic or add corticosteroid. And these features were that this patient was having a very long history of 6 weeks before it presented to us and 8 weeks while he was with us. He had a history of corneal foreign body that was removed by local ophthalmologist, and then this patient was showing waxing and waning course. All of these typical history and a review of the clinical data clearly suggested that we should do acid-fast staining, which revealed Mycobacterium chelone. It is important that we should take into account these cases where there is a typical history and suspect non-tubercular mycobacteria. Now, why is it important? Because these patients do not have a very characteristic clinical picture. It all depends upon what kind of predisposing factor they are in. Trauma is one of them, and the other predisposing factor is prior surgery. Number two, the clinical picture, although is described as a cracked windshield appearance, but is not often seen in analysis that we did at our center. Thirdly, that many of these cases do not stain well with the gram stain, which is a usual stain that we use. And therefore, most of these organisms remain undetected on microscopy. And unless the culture is carefully viewed, you are likely to miss. And the only source that we have is that a diagnosis purely depends upon the clinical vigilance of physicians. Once you make the diagnosis, the treatment is relatively easier. Amikacin is the drug of choice. If administered in 2.5% concentration, most of these patients respond. So to conclude, microbiology is important, particularly in severe corneal ulcer. Fluoroquinolone monotherapy is best reserved for small ulcers, and corticosteroids have no proven value and therefore should be used very judiciously. In chronic cases where you have started appropriate treatment and they are still not showing response, consider atypical mycobacteria. Thank you very much. And I'd like to thank Professor Namrata Sharma and AIOS for giving me this opportunity to share my views on bacterial corneal ulcer with you. Thank you very much.